Karen is the clinical professor of pathology and chief of the molecular diagnostics division with North Shore's affiliation with the University of Chicago. She's also the chair of molecular pathology and on the board of directors at North Shore University Health System. And let me navigate to you. And we're pleased to have Karen here today, drawing from the considerable talent in Chicago. I have to tell you, as a native of Chicago, this is the month and a half of informatics in Chicago. Not only is our meeting here, but the National Medical Informatics Association is here, and you got the mayor to declare this as Informatics Week. So I think that molecular and informatics still is not doing their job to get together. So I'm continuing to tug and pull at this very influential leader to help us along the path. So I'm very proud to have Karen here. Thank you for your time.
Thank you, Mike. We should have the mayor here in the back, I think. I guess I don't need a lavalier mic, so we're ready to go. No, if you can hear me fine, we'll just go with it. So anyway, no, I'm really pleased to be here, and I have become something of a convert. I will admit, when I got the call, I don't remember if it was Mike or Bruce who called me some months ago to ask me to speak at this. My first reaction was, speak at an informatics meeting, I'm a molecular person, what could I possibly say to this group that they would want to hear? And I thought about it a bit, and you know, I would draw my Mickey Mouse a little bit differently, perhaps with molecular and informatics in the middle and all of the other areas spinning out there, because I think that these two areas are really central to what we do as pathology. We generate data, we generate information, and it's our job to work with our clinical colleagues, the folks in the EMR, which we may or may not like the version of the EMR we work with, but we need to be able to deliver that information out in the most clinically usable way that we possibly can, because again, it's all about, you know, improving our patient care. So at any rate, I guess I would at this point describe myself as an informatics wannabe. So I'll talk about some very much in the trenches pilot projects that we've undertaken at North Shore over the course of the last year. So never given an informatics talk, but be kind here this morning. And why do I think we need to get into this? Well, you've heard these numbers at several junctures during the last couple of days here. Lab testing is a 4% of the total healthcare spend, depending on how you slice it. We generate, 70–80% of the downstream costs. The decisions are based on the data that we generate in our laboratories. And so while we can complain that we shouldn't get squeezed because we really are only 4%, we are definitely seeing some trends ahead that are worrisome for our field. Our increases in the lab are going up at a higher rate than the healthcare dollars, which may be due in part to some of the complex genetic tests. I think the area that I work in is certainly part of the problem there. But we're all going to get squeezed, and I think we need to, in the laboratories, do what we can to keep our institutions afloat, streamline, work towards better outcomes for our patients, do whatever we can to cut out waste and cost wherever we can. I think that's part of the job that we need to take on. And we can do this by working very closely with our colleagues that run our EHRs, work with our colleagues in the laboratories, working with our lab information system and whatnot, because in the end, if I can figure out which way this goes. No. Just use the arrow, I will, okay. You know, I think we've got a value equation there. Our value proposition in pathology is that we need to think about quality more globally than just the quality control that we do in our own laboratories. We need to think globally about the quality of getting patients' diagnosis better and more accurately and onto the most appropriate treatment. We can do that with the data that we generate, but we also have to look at the cost equation, and the mathematical equation there leads to better value in the laboratories, and so that's really where we've been headed this last year with some of the projects that we've been involved in. A few other comments you've heard during the course of this last couple of days. I think this is coming from Paul's work, and I'd love to find out which 40 or 50 lab tests those are. But you know, clinicians, I cannot keep up with what's going on molecular. I get questions, you know, on a weekly basis about some new molecular test, and I have to go to the literature and look it up because I can't keep up with it all. So there's no way we can expect our clinicians to keep up with molecular, and molecular is just a slice of what's going on in the lab. So physicians are comfortable with 40 to 50 laboratory tests that they understand how and when to order and how to interpret those results, but we need to help them with the rest of it. And again, this is part of the lab transformation that you hear so much about, is getting out there and helping our clinicians take better care of patients. So some months ago, we decided to jump into some laboratory utilization projects at North Shore. And I have to say, we weren't sure where to start. I wasn't sure where to start. Are tests over-ordered? Are they under-ordered? Is the problem the complex genetic send-outs that were, again, partly coming from my field, that we were sending out the door to labs and certainly not getting reimbursed for? Do we need better tiered algorithms, tiered testing to help guide physicians to use this? Well, the answer is, of course, all of the above. And you really have to start by doing a deep dive. So I'm going to do a very much in the weeds type of presentation here to talk about some of the things that we uncovered as time went on. But I'll also say that I did this with a lot of help from new friends I made across the institution. It really takes a village to get these projects underway, and so this was a wonderful opportunity to connect with folks who I hadn't worked with as closely as I should in the past. I lived in the lab world, I lived in my molecular world, and none of this would have taken place without a whole lot of time and patience on the part of folks like Ari Robichuk, who's our VP for Quality and Clinical Informatics, his Epic Optimization team and their wonderful analysts, Ned Wagner, who's our CMIO, who we've heard from at this meeting, and a whole host of other folks, including our two champions in our department who oversee our lab, LIS. Teamwork is really what moved things along. So just so you know who we are, this is North Shore University Health System. It's a 4-hospital system. This is the flagship institution where I didn't know you met your wife, but I'm glad to hear that, Mike, and we'll have you back there to visit sometime. We're about a 1,200-bed hospital system with a growing medical group and a sizable outreach operation on the north side of the Chicago metropolitan area. Our institution is fully Epic functional. For our EMR, the laboratories are not on Epic, but we've been at HIMSS level 7 for at least a few years and have implemented Epic going back about 10 or 12 years, so we're quite invested in all of this. And where we decided to start looking are the over-ordered tests, the genetic tests, and how to implement guidelines. And so I'll give you some examples of how we roll that out. Started with me getting reports out of our electronic data warehouse to try and figure out where we had problems. What tests were being over-ordered, nursing glucose on the floor, metabolic panels, CBC with DIF was one of our top ordered tests, number 3 on the list, and that was a little bit surprising to me. And you can look on down the line. There's not a lot of data out there. There's maybe 10 or 12 papers that look at overuse of lab tests, underuse of lab tests, but CBC with DIF is one that comes up on a number of folks' tickle lists as being over-ordered. And what was also particularly interesting in the next report that I got from our data warehouse folks was that we were seeing CBC with DIF as being one of the top tests ordered more than once a day. Do you really need a CBC with a DIF more than once a day? Probably not. The DIF will change a little bit, but 24 hours is certainly an acceptable window. It's not like a glucose. It's not like the crit. This stood out as a red flag for me as we started looking at this, as did magnesium, hemoglobin A1Cs, and a whole list of other things down the road. But CBC with DIF is where we started testing our mettle to see what we could do about this. Took a deeper dive into the data. One particular month, I think this was last January, we had 505 CBCs with DIF that were ordered more than once a day. 80 of those 505, or about 20%, were ordered when there was already something in the lab. Sample in the lab, waiting for the results, new order comes through, passes on through, and away we go. About 10% were ordered less than an hour after the result was released. Another 10% within 2 hours after the result released, and you can see on from there. So clearly there's some communication issues that we're having, even though we're as Epic savvy and plugged in as we think we are. So I used the Epic In-Basket and started asking questions and got about a month's worth of data back. Why were these CBC with DIFs being ordered and ordered and ordered again within a 24-hour period? And the results I got, people were quite willing to email me back, were this. About 60% of the time said it was an ordering error. They didn't really want a CBC with DIF, they wanted a CBC, but because CBC with DIF comes up first on the list, that's what they clicked, or they clicked it by mistake, or somebody else ordered it, or there was a problem there. About 20% of them said, with nothing they could particularly quote, but they just liked to see the numbers. 10% blamed another service, and in 10% of the cases, a very small number, were they able to say, well, the clinician situation has changed and they really needed to get that CBC with DIF. So clearly there is plenty of room for improvement here. Now, this was really a surprise to many of us because we do have a duplicate encounter box that comes up. This is an Epic function, and I am not an Epic expert, but this is digging into this a little bit further was a surprise to all of us. So At the time of order validation, if there is an order that's been placed for that particular procedure on a patient, this is supposed to pop up. But let me tell you, this pops up for every duplicate procedure during the entirety of a patient's hospital stay, whether it is a chest x-ray, CBC, crit, whatever. Every time you reorder one of those during the length of a hospital stay, this is going to pop up. And you say, do you want to accept these orders anyway, yes or no, and on you go. So if you're a clinician, it's 11 o'clock at night, you're taking care of your patients, and this is popping up every time during the course of that stay, what do you think you're going to do? Blow on through it, and that is exactly what appeared to be happening. So this was a good idea, but in practice, because it came up so frequently, people ignored it. They accepted the orders anyway. That was the default, as you can see, and away they went. So before we wanted to get in and start mucking around with this, we wanted to not create new screens that were going to slow down and frustrate our clinicians more, but see if we could get rid of this and put something more functional in. So with a little bit of trepidation, we turned this off. And what do you see? CBC with diff. We looked at a time frame while this duplicate order box was still on and had 470. We turned it off. Surprisingly, the number dropped. This is not a statistically analyzed patient set, but what you can see is it had no impact on the ordering of CBC with diff, nursing glucoses, basic metabolic panels. All of the ratios of the window before and after we turned that duplicate order thing off were essentially one, with a couple that went up and down a little more, and we had some lab explanations for that. So this clearly, again, was having no impact. So Annalyn Chu and Ari and his Epic optimization team helped us to design an order, and we had some requirements that we really wanted to put in place. We're concerned about a 24-hour window, so we wanted to search a 24-hour window before and after we were putting this order in place. We wanted something that would work across all encounters, and this was a little bit of a challenge, but we wanted it to work across inpatient, outpatient, ER, all the settings, and be looking for these orders. We'd like it to be a value to the clinician, not just a window that gets in the way of their daily work. So wouldn't it be great if it not only tells you there was a result an hour ago, but it pulls up that last result and presents that to the physician in a usable way, and shows the next scheduled time, so they can decide whether they want to cancel that order or the one that's been ordered in a new order set that's coming up the next morning that may have come from the other service, so they know what's going on here. Let's allow the order cancellation function right in this window that we're popping up there. Let's not have defaults. Let's make them think yes or no they want to order this or not order it. We have a lot of things at Evanston that are ordered via order set, so let's make sure that we cross that capability as well, and so on and so on. So a lot of requirements here. It's not always easy to do, but the wizards in the Epic optimization team were able to come up with this. A little bit clunky, not perfect, but this is what they were able to build for us using the methodology that they use to work within Epic. Comes up after signing the order, which is a little later in the process we'd like, but they now get a window like this. Procedure duplicate. Do you want to continue this order? You can remove the current order. You can remove the next morning order or whenever that has come up. If you want more information on who ordered it or who didn't, you can click there and it links out to more details about that order so you know what's going on. It tells you when things are scheduled, et cetera, et cetera. It doesn't bring up the last information, however, so it's pretty good. This is a little frustrating down here. There are no defaults. You can either continue to accept the orders, yes or no, but you really have to go in and click remove to remove one of these sets of orders. So it's a start. It's a start. Triggered upon signing, again, we'd like to have it earlier in the process, triggered upon ordering. What we'd also like to build in there is the ability to switch to alternative procedures. So CBC with diff is what's there. We can add or cancel that CBC with diff. But in most cases, I think what they really wanted was just a plain old CBC, and we can't, with the current technology, put that in as an option or switch it to a crit or whatever they might be looking for, which is, I think, most often the default. So it's a start, not quite where we want to end up yet. So in part, this is a plea to anyone who might be building these systems in the audience still that we need much more functionality in order to control this a little bit better. I'm going to skip this over. So this alert has been on for 10 days. I've gotten no complaints. We do have a little bit of data, not filtered or analyzed, but this alert fired 229 times in the last week. I am told that we are avoiding about 20 duplicate tests a day. That seems a little high. I would have expected it to be 10 to 15 range, but we appear to be having an impact, and I've got to go back next week and really dive into this data and find out how many of the total firings are resulting in an overridden or canceled result, how many of these are unique patients versus a frustrated person just hitting and hitting and hitting, and a whole variety of other things. So this is, again, very much a work in process. Oops, and why did that? Why do I worry about this, or why should we think about this? You know, again, in the labs, we're all concerned about what's coming at us financially. Focusing on the inpatient labs, how much do you all get reimbursed for inpatient lab testing under DRGs? 3%, maybe 2%. So basically, we're almost doing the inpatient lab testing for free. Anything that we don't need to do is waste, and we should be finding ways to get rid of it. And this is really a function to try and get us to get rid of these things. So going back to our target month where we had 505 replicate CBCs in a given month, you know, CBCs are cheap. Why should we worry about this? You know, to run on an instrument doesn't cost anything. Well, the reality is it costs about $4 in reagents and a little bit of tech time every time a CBC is ordered, but 20% of those are abnormal. The platelets might be a little high, the CBC is out of range a little bit, so 20% at our institution get a manual smear and manual review by a tech in the lab, and that gets a little more expensive. That's around $10 during the day, higher at night with a shift diff. So things start to add up. And using our sample month of 505, if we were able to avoid those, we'd save, you know, $2,000, not a lot, in a single month off of the reagents for the regular CBCs, but it starts to add up with the manual. So $3,000 a month for one test. You know, pretty soon we're getting into the range of, this is a salary of a med tech for the course of a year, and this is one test. So it is going to add up. Another area a little nearer and dear to my heart is once-only tests. Your germline does not change. You're stuck with it. So Mike Laposada talked about, you know, the calls he gets from clinicians about, you know, alleles, people not understanding alleles. Now this is, you know, we get a lot of still interesting calls. Fortunately, that's gotten better. In the early days when we started offering things like factor V Leiden, I would get calls from clinicians saying, what's a heterozygote? And I would also get a lot of calls from clinicians, again in the early days, this has gotten better, who thought they needed to repeat the factor V Leiden before and after anticoagulation, as though it were going to change. So people are a lot more sophisticated about these things now, but we still see duplicate orders on germline tests. And factor V may be one of them, prothrombin, MTHFR, all these sorts of things. I think one of the biggest offenders in our practice is cystic fibrosis carrier testing. So this is offered to all women, ideally before they're pregnant, but what typically happens is they get CF testing as a way to identify whether they're a carrier or not, and it usually comes in with the prenatal labs around week 12 or whatnot. It is much easier to reorder that test than it is to go looking in Epic to find the results from the pregnancy they had 3 years ago, 5 years ago, or whatnot. So it gets reordered, it gets repeated. This is costing a few $100s. Gets even worse with something like spinal muscular atrophy, which at our institution is a send-out. We're paying something in the order of $500. We sure don't get reimbursed that. But again, easy to reorder. It's part of the prenatal order set, and away it goes. So we began to worry about this more and more as we are doing more and more germline genetic testing, and realized we needed to build a tool to give us a handle and some control, and not just my excellent techs in the lab remembering this name looks a little familiar and thinking back and catching it in that way. And surprisingly, these weren't being caught in any other mechanism by duplicate order functions that we had in our information systems. So I think the real question is accessibility here. It's just hard for the clinicians to take the time to go back and find those results. So we built using a BPA, best practice alert. In Epic, we built an advisory. Again, it's a little clunky, it's not perfect, but what it does is looks over all encounters, inpatient, outpatient, whatever, back 10 years to the days we started having Epic, and looks to see if this patient has had this test. And if they have, it pops up into here, There's been this test. I don't know why it says it twice, but it does. I guess it's for emphasis. Tells you the date of the encounter. You can click on that date and get a link to the old results and see what it is. And so we're trying again to just get these information in the hands of the physician in a time that they use it, and hopefully they will cancel the current order and go on from there. FYIs we use to inform our physicians. I would love to put a little one-liner at the bottom saying, if you call this number, we'll pay you $100, because I unfortunately think a lot of these FYIs don't get read by our clinicians, but this is a recent one when we went out with this once-in-a-lifetime alert going live this summer across all of the spectrum of germline tests that, we're no longer going to be allowing these to be done. We have a little bit of data. We actually deployed this in June, and this is a little complicated, but in the first maybe 3 months of having this active, this alert, looking only at CF and factor V Leiden, so just a subset, it fired 78 times. It was overridden 21 times. So we prevented 57 tests, which is good, but why is it being overridden? Why are people ignoring it? Well, lesson to ourselves in the laboratory, these are largely outpatient tests. They come in at night through our outreach. The couriers come and drop things off, and if things are not ordered in the computer, we have a team that does the, order validation and such. We had not instructed them about this alert. And so they were following the orders that they were getting from the clinicians, overriding our alert and going on and ordering it anyway. So these 21 alerts all came from our own in-house outreach, and now we know better. But we did prevent 57, so it does have an impact. Again, got to come back to the dollars. What's the impact here? Well, a cystic fibrosis test cost to the lab is somewhere between $85 and $100. Hypercoag test, if you do the whole panel, is probably somewhere in the order of $85 to $100. We estimated very conservatively, when I calculated this, that we could prevent about 150 of these a year. We actually think we can go much higher, but again, we're adding up. We're at about $40,000 and counting just for those 2 tests. You start to think about the send-outs, the SMAs that we don't get reimbursed for that cost $500 a pop, all the other pharmacogenomic tests that are coming at us, and I think we need to have this functionality in place. A variation on this theme, once positive, don't repeat. It wasn't on those tables, but one of the other most frequently ordered tests, hepatitis C serology. It's in a whole lot of order sets. Patients get it on admission. They get it at various points at which they intersect our medical system. And in fact, all of us baby boomers are supposed to have it, so they're really pushing it. But what we know is that it is typically just ordered, and once you're positive, you're not going to be negative again under most circumstances. So once it's positive, turn it off. Don't reorder that. Just pull up the old data and do this. And this goes for Hep C, CMV, HIV. People usually know if they're HIV positive. But we're starting to monitor this and see what we can do about once positive, turn it off. We're collecting baseline data. We're currently building the alert. We had about 3,600 hepatitis C serologies done. Most of these were inpatients at our institution over the last year. 220 were repeat orders, about 10%, and 10% of those were already positive. So, again, the numbers will be small, but we're starting to take a look at this model for how we can impact upon the ordering being repeated. A little clunky, the BPA isn't ideal, but it will allow us to hyperlink to things in the chart to pull up the old information. This is a work in progress, but just another example of, I think, where we need to think about going. And I had the pleasure of meeting Brian Jackson and Brian Schertz, who may still be here in the audience. We also have a problem with adherence to guidelines, and HPV is a very hot topic these days. We're now thinking about not only using HPV to add to what we can tell from a pap smear, but we're using it to lengthen the interval between pap smears. We're now thinking about HPV 16 and 18 specifically as determining who goes to colposcopy, who's really at a high risk for developing a malignant process there. So there are guidelines out there that have been publicized. We shouldn't be doing HPV testing if you're under 21. In that window between 21 and 9, you want to use it to triage ASCUS, so you want there to be a cytologic abnormality. Again, women in the younger age groups often clear HPV with no bad consequences, so we really don't need to be acting on this HPV positive in that window. But beyond age 30, it can be used for primary screening. It does does tie in very nicely with the risk of cervical cancer. And in fact, if you have repeated negatives, you can extend the follow-up interval for repeat pap smears or HPV screening. So those are the guidelines. We know they're not being followed very well. We've got maybe a little bit of hope from improvement based upon this publication from the folks in the audience. But how could we start to employ lab information systems or hospital information systems, the EMR, to enforce these guidelines? Well, there's some challenges. What information would we need? We would need patient age. Pretty easy. We can pull that out of the medical record. Screening and pap smear results. Is that easy to get out? It's not easy at most places because it's text. So we get back to that issue of discrete data elements. And if we're going to pull it out and get it out of at our place, out of the data warehouse, we need to redesign all of our pathology reports. CP is a little better, but on the AP side, we're dealing with lots of text, and we need to pull something out of there so that the machines that we're building, the tools that we're building, can see what the pap smear result is and correlate that with age and move on. And then we need to also be able to look at the last time they had their pap smear. You know, what's the screening interval there? And if we can gather these 3 bits of information, we could start to think about building some sort of an automated tool, an alert that might come up to facilitate physicians ordering these tests according to guidelines. Now, we're still going to have problems with patients, and in our patient population, we get lots of patients coming in demanding the tests they wanted. But what we're also seeing is that we're not necessarily getting reimbursed. Third-party payers are increasingly adhering to the guidelines and not paying for patients that fall outside of these parameters. So I think it's going to behoove us to find some ways to address this as we move forward. So survey across encounters. Over years, we need to be looking at data and some way to deal with the data in a discrete way that allows these tools to be done. Last one, and we haven't really done anything here other than starting to think about this, but this was a big issue at our house, and again, hits close to home because we're part of the problem with the genetic tests. The number of send-outs that we are processing at our institution for complicated, novel, sometimes only one place in the world like Prometheus or other places that will do the test is skyrocketing, and it's not uncommon for me to get an order from a neurologist or a pediatric endocrinologist for $25,000 worth of testing to be sent out, and we're certainly not getting paid for this. So how we get a handle on management of these complex, genetic, serologic, and neurologic test requests is an issue. Send-outs, they're often over-ordered. There's typically no triaging of, this mutation might hit 50% of all of what causes that disease, so you might want to try that single site first and then go on to the next tier of tests. So we need to build some logical tools to help us there. The biggest problem we have at our institution, however, is that most of these are ordered on a miscellaneous test code. So there's no way for us to send these off to deemed users or experts in the laboratory to review and help triage how these patients should be most appropriately worked up. And it's such a wide range of things, we can't have a single person in charge. So we're going to need to build a variety of new test codes, which is happening right now at our institution, to sort of put these into pockets where we will know that they have to go to the neuropathologist or the molecular genetics folks or so on to try and figure out the best way to handle these requests and get the right test done in the right time. It's not all just about the money. So I'll close here. I want to say thank you for the invitation to be at this meeting because I am a convert. I think, again, molecular and informatics is key to our evolution as a field, and we all need to embrace it and become informaticists in some way, shape, or form. And I'll take any questions that any might have. Thank you.
You're not going to be able to escape just so easily.
Thanks, Alexis.
So I have 2 questions for you because at Emory we have also done a lab test utilization review. We have taken a bit of a different tactic because we saw a lot of the same things that you saw where the duplicate warnings were not working. They were just blowing through them. So instead, the tactic that we are beginning to take, and my question is kind of, have you considered doing this, which is to get rid of the warn, set your parameters a little bit narrower, and do a deny, like they can't order it within a certain period of time.
A hard stop.
Yeah, it's the hard stop.
Yeah. We've talked about hard stops. They're not liked at our institution for a variety of reasons, so we haven't gone that far. I know some places have done it, but we, at this point, are trying to be more guiding rather than
Right.
brick wall in our approach.
Well,
So-
our physicians actually took a little bit of a different tactic because they were so tired of all of the adverse drug warnings that they were getting that they had serious alert fatigue. So ours have actually so far been quite accepting of doing a deny because it's one less set of warning windows that they have to get through. Because the number of ADE, warnings that they're getting is just, is killing them. The second question I had for you is that when you implemented the warnings for we need to never repeat these tests, because I agree with you, germline genetics, there's absolutely no reason to redo those. The issue that we have run into with a couple of our things is that the query length, that going back through the patient's record over many years that they may have been at Emory, we're worried a little bit about the risk of a slowdown. Have you seen that in your system where basically the screen hangs because it's looking for that patient's test over a long period of time?
I've got no complaints, but I will certainly ask that when I get back. We may just not be pushing the limits of this, and, it's something we'll have to be aware of as we move into it, so.
Okay. And then the other thing is that we need to talk about AMP.
Okay. Thanks very much, Mike, and I'll see you next year in Pittsburgh.
I do have a question.
Okay.
Ray Aller from USC. And first of all, your comment about the FYI newsletter that nobody reads, very important to continue publishing that, because there's another three-letter acronym that it provides.
Yes.
CYA,
Got an eye
yeah.
on it, too. Yeah.
And, over the years, I've gotten more grief from clinicians that said, you didn't tell me you were going to do this. And if I didn't have evidence that I told them, then I was in trouble. But if I could say, well, there's this newsletter, I'm sorry you didn't read it, but you did receive this, then they have much less ground to stand on to fight against you. The other, just a brief editorial, and then you comment about the delay in the database search at Emory versus where you are, it seems to be quick. You have a better database. You have a better architecture of database than they do. I'm sorry, no, I tell that to anybody who is willing to listen, but, the databases we're all operating on are not the same. Some are better for medical care and others are not, so, okay.
Could be the case. I don't know what the background information is, but it's certainly something, as I said, I'm learning, so we'll go back and ask those questions. Thanks, Alexis. Thank you.
Thanks, Karen. Okay, we always leave the best for last.